Hey everyone, I know we had such a long lecture on Monday, so this is going to be a super brief review just to go over everything that we talked about. So we started with the current mental health care system in America. Right now it's based on a private insurance model. Most Americans don't have insurance or are underinsured, especially in Texas. Texas is the last state in the nation when it comes to mental health care in America, and in part that's because so few adolescents and pediatric patients have access to health care. Most Americans are insured by a public program, by Medicare or Medicaid. We have two different main types of care settings in mental health, inpatient and outpatient. Inpatient's based on needs, and that need is usually because the patient's a danger to themselves or a danger to someone else. And inpatient care provides a stable 24-hour a day therapeutic model, and the main goal is to keep the patient safe. Some of these patients may be committed by the criminal justice system. Those are usually called jail diversion programs. We have one locally through Bluebonnet Trails. Outpatient care is in the home environment. There's multiple different types of outpatient care. You could have home health psych nursing. You could have just going to your therapist or going to your psychiatrist, intensive outpatient, partial hospitalization, tons of different models. But these are patients who are usually safe. They're stable. We're not concerned about suicide. We're not concerned about homicide. The community support system model views clients holistically. And basically what this means is an individual with mental health doesn't just need mental health care. They might need help getting housing or crisis response, peer support, and also the family might need support. So this is more of a coordination between social, medical, and psychiatric services that kind of ties everything together. And usually that tie that holds it all together is a case manager. The case manager could be a nurse or it could really just be anyone. This is a table pretty much directly from your textbook that goes over all those different models. So emergency care, that's where you'll be doing clinicals. That is Georgetown Behavioral. It could be a standalone psychiatric facility like Georgetown Behavioral. It could be your local emergency room. It could be some hospitals have a specific unit inside them, kind of how you have med-surg, ICU, pediatrics, and you could just have a psych unit inside a hospital. And this is short-term care. It's designed to stabilize the client. So the average length of stay in emergency care is usually 5 to 7 days. Now, if you're talking about like an emergency room, where we bring a patient to emergency room, that honestly might be a day or two because sometimes we might not have a bed. But traditionally, like Georgetown Behavioral, when the patient's going to be there and we're doing our best to get them stabilized, 5 to 7 days. Nurses, social workers, psychologists, psychiatrists, a lot of them will be there. And we're not going to fix the patient in this environment. We're just trying to stabilize them so that we can step them down to one of the other levels of care. Group home. We see this a lot sometimes in addiction medicine, in eating disorders, where it's a protected environment with other individuals who might have the same condition. Partial hospitalization, also known as day treatment. You sleep at home at night and then you go during the day. You visit with your therapist, you attend groups. Psychiatric home care is just like any type of medical home care. You might have a psychiatric nurse who stops in during the day, checks in on you maybe once a week. And then you have community mental health centers. Crisis intervention, family counseling, they could do assessments, vocational skills and training. Bluebonnet Trails and Integral Care are the two local to Central Texas who we have here. This slide goes over some other community resources. Case management's that link. It links different services together for the client. Psychosocial rehab. Some of these patients might need help learning skills. The patient may struggle to hold down a job or to communicate with others. And psychosocial rehab really helps the patient learn how to live independently. Consultation is getting a specialist. Sometimes maybe we need to pull in an addiction medicine, or if it's a pediatric patient, a developmental pediatrician. It's grabbing someone else who has extra knowledge in that specific area. Resource linkage is just what it sounds like. We're going to link the patient up to resources. There are tons of community services out there that patients don't know about. Advocacy, the client might not know everything that they need to know to make the best decision. And advocating for the patient and having someone who's there can help them. We give them all these services. They might not know that, hey, this is the next best step to take. Therapy is just what it sounds like, one-on-one or group therapy, where they can talk about what's going on. And crisis intervention, in that moment when everything is going wrong, something to help the patient. There are a lot of different members of the multidisciplinary healthcare team. The psychiatrist is that medical doctor who has done extra training in psychiatry, and their main role is to prescribe medications and to diagnose the patient. Clinical psychologists can also diagnose, but they do a lot more of the diagnostic testing. Think those old school ink blot tests. That's what a clinical psychologist will do. They're less likely to prescribe medications. Some psychologists can do additional training to be able to provide medications, but it's not done often. A psychiatric social worker has a degree in social work, and they do one-on-one therapy with the patients, family therapy, or even group therapy. Psychiatric nurses is a nurse at any level. It could even be a master's degree nurse or a doctorally prepared nurse and a psychiatric nurse practitioner. And we help with all areas of the client. We're concerned with their activities of daily living, their assessments, how they're going about in the day room. Psychiatric technicians, all you need is a high school diploma and a lot of on-the-job training. They are really the backbone of the program. They manage the milieu. They manage that unit. They supervise the patients. They're rounding on them every 15 minutes. Occupational therapists, socialization, vocational training. I've honestly never seen an expressive therapist. I've seen art therapists and music therapists. I've never heard it called an expressive therapist. But patients love it. Let's get them together. Let's get them socializing. How do you express yourself in a different way? Recreational therapists. A lot of psych patients struggle with self-image and socialization skills. And rec therapists are amazing in getting the clients up and out, getting them moving. Let's play sports. Let's listen to music. Y'all will love the rec therapists that you meet at clinical. They're amazing. Dietitians. They make your cafeteria menu. But then also if you have a patient who has diabetes and it's out of, unmanaged because the patient hasn't been taking care of it because they've been focused on their meth addiction, they come in and do a great job teaching. Auxiliary personnel, we still have housekeepers, we have secretaries, volunteers. Some facilities may have a chaplain if needed. High-risk client populations. It's important to know who is at a higher risk. Community mental health care was originally designed to provide prevention, education, and treatment for all members living within a community. And this includes crisis intervention. When we bring up the opioid epidemic, we're seeing more rural individuals, children, families, adolescents affected. And this is when we say, and I said this in class, when I say children, families, adolescents, older people, it sounds like everyone. But it's really being able to identify who is the most at risk. One of the examples I gave in class was, my grandmother. She's, in her mid-80s. She just moved into like her own little condo out of kind of the bigger family home, so it's smaller, more easily for her to manage. She still drives. She has health insurance. She's connected to a senior citizen support group. She goes to the senior citizen center all the time. She goes on outings. She has her little widows group, they call it, that she goes on trips with. And even though she's had some health problems recently, she has stabilization and support, and she has 2 children who live right down the road. She would not be high risk. Now, if you have an older gentleman who's HIV positive, retired military, lives out in the country, maybe 2 hours from the nearest VA, he has a car, but he's been struggling financially and the car doesn't work as well. His wife's passed away and he doesn't have any family nearby. He checks off a lot more of those boxes. A military veteran who's struggling with addiction, who's living on the streets, checks off more boxes than a military veteran living in suburbia 20 minutes from the nearest VA. So we have to be able to kind of look and see if we're looking at these people who would be the most at risk. Impact of mental illness: 25% of the world's population will experience mental illness during their lifetime. 18% of American adults live with mental illness. This doesn't even talk about adolescents. We're seeing higher and higher rates of adolescents struggling with mental health care. But funding hasn't kept up. We're getting more and more, and especially in the last few years, most states are cutting money from their budget. From 2009 to 2011, states cut $1.8 billion from their mental health care budgets. And when we bring up all those social issues, right, post-COVID, poverty, homelessness, the cost of houses are rising. The increase in substance abuse, fentanyl is rising. We're seeing substance use in adolescents decrease, but fatal overdoses in kids are increasing by 83%. These are huge impacts that mental health has on society. So the ethical and legal issues. Attitudes shape our point of view. Beliefs is that conviction. It's what we accept as true, whether or not it's based in fact. Values is a feeling about the worth of an item, idea, or behavior. We all value things differently. And morals kind of tie it all together, right? I always like to think morals kind of what we believe are right and wrong, and that's based on those attitudes, beliefs, and values. Rights. Power, privilege, existence to which one has a just claim. It defines those social interactions, and it's associated with obligations. We all have the right to be respected as human beings, to be treated with dignity, but they have obligations. We can drive down the road, but to be able to drive down the road, we have to obey the traffic laws. There is a client bill of rights because all of our clients have rights regardless of the fact that they have a mental illness. Care, privacy, confidentiality, to get relevant information, right? You can look at your bill, you can refuse treatment, and a right to participate in research. These rights used to not exist. As care providers, we have the right to be treated respectfully, to safety, both physical and emotional, and competent assistance. So what competent assistance means is that our CNAs who are assigned to work with us, they should be adequately trained. They should know their job. Our coworkers, our fellow nurses should know how to do their job. Honestly, even your therapists, your psychiatrists, everyone. Ethics are the rules that govern behavior, and they combine the values, the morals, and the what is right and wrong. When we talk about this medically, we're looking at biomedical ethics, bioethics, or medical ethics is usually the term that we see. Now we have a bunch of ethical principles in medical. Autonomy. Patients have the right to make their own decision. Beneficence, do good. Non-maleficence, do no harm. Justice, treat everyone the same. Confidentiality, don't be gossiping about your patients or making TikToks about them. Fidelity, if you say you're going to do something, do it. And veracity, always tell the truth. Don't lie to your patients. There are a bunch of code of ethics. The ANA is one of my favorite, the American Nurses Code of Ethics. It talks about our ethical rights as nurses. It helps explain some of those gray areas in those situations that we come up with. And they all say the same thing. We need to support our clients. We need to be truthful. Consult your supervisor if there's ever any questions. And it's important to remember as nurses, we need to practice with these ethical principles in mind. An ethical conflict exists when there's uncertainty or disagreement about what to do. These ethical conflicts and these problems arise when it can't easily be solved by decision-making logic or scientific data. And in mental health, and some of y'all have already sent me some questions, right? We have a lot of gray areas. Is this right or was this wrong? And those are where the ethical conflicts come in. One of the ones we talked in class and we talked about a little later on too is that duty to warn. If you have a patient and they're threatening to kill someone and we're about to discharge them, do we warn the person? Do we break HIPAA? And the answer to that ethical dilemma actually was answered legally, yes. We have a duty to warn individuals. The laws and legal systems are derived from the rules and regulations, and it's how we govern ourselves. Federal laws trump everything, and they're based on the U.S. Constitution. State laws are based on the state constitution. So though you can go to Colorado and marijuana is legal in Colorado, federal law still says it is illegal. We went through and talked about a lot of these little terms, kind of assault and battery. Assault, threatening your patient. If you don't take this medication, I'm going to give you a shot. That is assault. Forcing a medication. If the patient says, I don't want that medication, I don't want that shot, and we give them the shot, that is now battery. False imprisonment. If you place your patient in seclusion or restraint and there was not a reason to, that is false imprisonment. Negligence and malpractice are on a later slide. We'll talk about those then. So legal concepts in healthcare. There are a few different types of things that guides us. We have our Nurse Practice Acts, and those are governed, it's state law. Each state has a set of Nurse Practice Acts. I highly encourage all of you to become familiar with your Texas State Nurse Practice Acts. The facility we work at has policies, and we need to be familiar with them, or at least know where to find them, because we are mandated to follow them. And then each type of nursing has a standard of practice. The American Nurses Association has a standard of practice for all nurses. As psych nurses, it's the American Psychiatric Nurses Association. In coordination with the American Nurses Association, they actually publish a scope and standards of practice specifically for psych nurses. They just published a new one actually not that long ago. And that's helpful and important to know because we're responsible for it. The laws in mental health care. We enter into a client-caregiver relationship, and it's a contract. And we assume liability on if something happens. Adult psychiatric admissions have two types, voluntary or involuntary. A voluntary admission would be me walking up to the facility and saying, hey, I'm struggling mentally. I don't think I can keep myself safe. I feel really unsafe. I want to kill myself. I have a plan. This is how I'm going to do it. And I sign a piece of paper and I voluntarily sign myself in and admit myself to the psychiatric facility. I am then considered a voluntary admission. An involuntary admission is my favorite patient who was once running through Whataburger naked. And he was talking about the world ending, and the police were called, and the police get there and they assess this guy, and they're like, he is not mentally stable. They picked him up, they took him to a psych facility, and they admitted him to the psych facility. He was there on what was called, 1 minute, y'all. I apologize for my children and that interruption. So the involuntary admission, the patient was brought by the police officers to a psychiatric facility. In Texas, it's called a notification of emergency detainment. It's a one sheet of paper. And there, that one sheet of paper admits the patient to the psychiatric facility for 72 hours, 3 days. And that's an involuntary admission. Now, if I'm at the hospital and I say I want to leave AMA and I'm a voluntary admission, I can now leave. But as an involuntary admission, I am now there against my will. It is a matter of safety. So for that 72 hours, I cannot leave. Areas of potential liability, we still have to balance client rights with the need to protect society. We have a lot of crimes in the healthcare section, homicide, controlled substance violations, theft, and we have to be aware of those and understand we might want to keep a patient in a hospital, but sometimes we don't have a reason to. Now, we talked a little bit about some of these on some of the other slides. Fraud, that cases out of Florida, everyone pretending to be nurses and getting those fake licenses. Those nurses are not nurses. Defamation, I am a psych nurse. I can tell you right now, this person, they have this psychiatric condition. If I don't know that they have it, I should not be talking about them. But also, invasion of privacy, even if I do know they have that condition, I should not be talking about it. Assault, threatening the patient. Battery, putting your hands on the patient when you don't have a reason to. And false imprisonment, restricting the client's movement, locking them in restraints or seclusions. And even if we do restrain or seclude the client, and we're going to talk about this later in the semester, there are policies and procedures, a lot of them that we need to follow. Negligence is omission, right? That perfect nurse in that perfect world, what would they do? So negligence is not doing it. If I know that I'm supposed to round on my patients, but I'm really tired, it's been a long day, they'll be fine, and I don't check on my patients and something bad happens, that's negligence. Now, for malpractice to occur, there has to be damage to the client, and that damage has to be caused by the healthcare provider. And we had to have owed a duty to the client. So if I'm supposed to be rounding on the patients and I fail to round on the client, I breached my duty. I had a duty to round and I did not. And the client kills themselves. That could be considered malpractice. When we look at malpractice and negligence, there's no foresight into it. There's no plan. It's not like we go into work and I say, I'm going to kill my patients today. It's usually a result of an accident. Maybe we don't look, we don't do our 6 rights when we're giving a medication. And I know I have confused the name of medications before. Some of them are so similar in name. I honestly once was talking to a provider and the provider's like, what are you talking about? Because I used the wrong name of a medication. It was a similar name, look-alike, sound-alike medications, right? It's as little as that, those simple mistakes and the things that we're supposed to be doing when we drill in the 6 rights into your head and the checking 3 times before you give meds. That is to keep malpractice from happening. So we have responsibility as the care providers to help the clients cope. We want to treat them as humans. Elopement's a hard one. It's a special situation when a client runs away or elopes from the institution. Where this becomes gray, because if we fail to prevent the client from eloping, we can be held liable if the client is injured. However, we also can't chase them down the street. Sometimes things happen. I have had patients elope before. And we just have to remember our facility policies when it comes down to it. All caregivers have a duty to warn. In situations, the client states, my husband's been cheating on me. I can't believe he did this. When I leave here, I am going to kill him. If our patient's telling us that over and over and over again, we need to document it. And we also need to warn the client's husband. There are state laws related to it. For NCLEX world, we all have a duty to warn. Reasonable, prudent caregiver. This is always what you have to have in the back of your mind as you're getting ready for the NCLEX. What would that perfect nurse do in that perfect situation? They're following the nurse practice act, the standards of practice, their employment policies, their job descriptions, right? They're competent, they're safe. That is what we have to think about. So I'm going to talk really quickly about this one. A client who is voluntarily hospitalized has just refused to take his morning medication. How should the nurse respond? Well, he's voluntary. So if a client refused, I just say, okay. I might ask why, so I can let the provider know, is there a reason why you're refusing? Maybe there's a side effect going on. But for the basis, I would just document client refused medication, and then I'll make sure to let the doctor know. Right? Hey, Dr. Joe, patient A refused his medication. He says he's been having constipation and he thinks it's caused by the medication. Sometimes that's true. A client's been threatening other clients and implying by his words and gestures that he could become violent. Is it appropriate to restrain the client? Is it legal? What should you tell the client if he insists that he has no right to touch him? If he's a danger to himself or others, then we can physically restrain him. And it's a gray area. And this one's kind of hard to read into. I would want to see what the client's doing, right? If the client's threatening someone and he's punching a wall, I'm just going to let him punch the wall. If the client's posturing and he's walking towards a pier and he's been threatening that pier, I'm going to step in, I'm going to intervene, and then we will restrain the client. If the client says we have no right to touch him, I'm going to let him know you're hurting someone else, and I'm going to take steps to keep everyone in the unit safe. The history of mental health care. There's a whole lot when we consider the history of mental health care. At a whole, mental health and mental illness is always on a continuum. On one side, we are right high level of wellness. We are perfectly functioning. Everything is going well. We have self-confidence, we have self-esteem, our anxiety is low, our depression's low, everything is great. On the other side, you have severe mental illness. And when we talk about severe mental illness, this isn't depression or anxiety. This is major depressive disorder. Maybe someone who's lost weight, they can't get out of bed, they have no energy, schizophrenia, bipolar disorder. If we look at someone who has mania, right? We'll talk later in the quarter about multiple personality disorder. It's not called that anymore, but dissociative identity disorder. That's where we see that severe illness. And at any point in time, someone can go from one side to the other. I have coping skills. I have the ability to adapt to change, to adapt to circumstances. But what happens when my coping skills are overwhelmed? I have coping skills to deal with getting a flat tire. I do not have coping skills to deal with seeing my child get murdered. And if that were to happen, I could go from the high level of wellness to that severe illness in an instant. Mental health is influenced by 3 factors: inherited characteristics, childhood nurturing, and life circumstances. A lot of our mental health conditions are inherited and genetic. Autism, there's a genetic component. Schizophrenia has a genetic component, right? Statistics that always blows everyone's mind in class. Schizophrenia is linked to there's a mild increase rate of schizophrenia in individuals where the mother had influenza during the second trimester of pregnancy. Childhood nurturing. How do our parents raise us? Do they teach us coping skills? Do we have the skills to cook dinner, get dressed, have a job? Were we abused as kids? Are our parents violent, aggressive? Are they hitting us? But then also your life circumstances, socioeconomic status. Where do you live? Where do you go to school? Were you involved in any trauma, right? Life circumstances. We can take 2 individuals and one of them could be involved in a school shooting. A school shooting would be a life circumstances which would affect someone's mental health. So what is mental illness? A mental illness is a disturbance in one's ability to cope effectively. Our coping skills are overrun. We cannot cope with change. Now, students always try to diagnose themselves with all sorts of things later on in the semester as we start getting into our disorders. However, it is not a mental illness unless it interferes with daily activity, it impairs judgment, and it alters reality. Now, the definition of psychosis is altering reality. So if you have psychosis, if it's impairing your judgment and it's interfering with daily activities, then yes, it could meet criteria for a mental health disorder. But otherwise, you can, just like, you can have pain, you can just have anxiety. But as a whole, mental illness, it's a disturbance in that ability to cope effectively. Because individuals who are mentally healthy, we can adapt and we can cope. Now, the history part. Primitive societies, right? There were evil spirits. And that is how treatment was geared. Early societies believed that everything in nature was alive with spirits, and illness was thought to be caused by that wrath of evil spirits. They would masks, noise, vile odors, charms, spells, bleeding, massages, induce vomiting, trephining, I can never say that word, but cutting holes in the skull. They would cut holes in the skull because they thought that would encourage evil spirits to leave. And historically, you were allowed to remain in society as long as you were not violent. You might just be that weird old guy who lives in the woods. Violent members were often sent to fend for themselves, or they were locked up in prison. The first institution for the mentally ill was founded in 1247. Bethlehem Memorial Hospital was a lunatic asylum. That's probably one of the most historically famous, opened in 1330. And throughout that time, you were chained to the walls in cells. It was cruel. It was inhumane treatment, honestly, up until the 1500s, that Protestant Reformation. We started to kind of look, and that's where we see recordings, melancholia, mania, some of that psychopathology. And in the 17th century, it was worse. We were starting to make observations and speculations about insanity. However, we were still beating, starving, and just chaining people to walls. 18th century is when psychiatry really became its own branch of medicine. However, the inhumane treatments were still going on. They were being openly questioned, but that doesn't mean much was going on about it. Pinnell in 1792 was one of the first ones that started saying, like, hey, these mentally ill people, they're still humans. In America, that Philadelphia almshouse was one of the first places in America, and that was in 1731, to take care of them. However, especially in the United States, it wasn't until after 1884 when we really started looking at the care and treatment in the United States. Benjamin Rush in the early 19th century, he published the first psychiatric textbook. And that's when once insane, always insane was no longer being accepted. Dorothea Dix was in the mid-19th century. She was a school teacher who started questioning the treatment of prisoners and individuals with mental illness. And she worked tirelessly to expose the conditions and to change legislation and to look at actually making mental hospitals with standards of care. By the late 1800s, we had a two-class system, private care for the wealthy and public care for everyone else. I will tell you, honestly, that has not changed. We do still have some private care type facilities in psych. In the 20th century, Clifford Beers wrote The Mind That Found Itself, and we had the Committee on Mental Hygiene in the 1909 that tried to remove the stigma associated with mental illness. And it tried. However, we still have that stigma and none of that's changed. Psychoanalysis came about in those early 1900s, and that's Freud. And we'll talk about him when we get into those theories. But it was really that first comprehensive theory on mental illness. Now, his theory is based on this theme of sexual repression, sexual energies, that oral anal fixation. And Freud believed it was that inside forces, right? You had that unconscious thought within you that's projecting outside, and that is what's causing the mental illness. Now, during times of where we always have amazing movements forward in healthcare, World War I and World War II, and honestly Korea and Vietnam, helped do that a lot for psychiatry. During World War I, a lot of men were drafted and they were considered too mentally deficient to fight. Early treatment in mental health during World War I was close to the fighting front. If we were talking about shell shock, they would remove men from the trenches, send them back a few feet, quite a few feet, but send them back still kind of close to the front line, sleep for a few days, and then they would send them back. Amphetamines were introduced. We wanted to keep people awake. Insulin therapy was used for schizophrenia. ECT started coming out. Lobotomies helped eliminate violent behavior. They would go through the frontal lobe into the from the thalamus. Either way, we had all these laws passed. National Mental Health Act after World War II. The National Institute of Mental Health was organized. We kept seeing post-traumatic stress disorder. We started realizing, hey, this is what's going on. And there was a lot of increased funding during that time. Also during this time, we started to see psychotherapeutic drugs. Thorazine was introduced in 1956, and we realized it helped control behaviors. John Cade discovered lithium and realized, hey, this helps with this manic depressive illness. So how did the advent of medications and these treatment of people with mental health disorders, how did the advent of medications affect the treatment of people with mental health disorders? Well, we thought there was something to fix them. So what did we do? the federal government started something called deinstitutionalization. And the whole reason deinstitutionalization happened was because of medications, right? So in 1955, there was 560,000 psychiatric hospital beds. Nowadays, somewhere in the 30,000s, I can never get the number right. I think it's 38,000 psychiatric hospital beds in America. So while we used to keep individuals with mental illness in the hospital, after the medications, we're like, wait, they can live within the community. They can do everything on an outpatient basis. So we started slashing hospital beds. And that was all because of medications. Now, we have had so many different congressional actions since then, right? Community Mental Health Centers Act, that is one of the primary ones that we saw in deinstitutionalizations. This Medicare Medicaid bill of 1965 honestly still affects it because it's preventing individuals nowadays from still getting treatment. I can talk about that one for a while. But we saw, right, the NAMI. We had a first comprehensive survey and looking at adult mental health care systems in years. And most of this stuff isn't happening. One of the bills that I love that is not on here is that Mental Health Parity Act. And that happened in about 2008. It's actually called the Mental Health Parity and Addiction Equity Act. And what that one does, especially when we look at like the Affordable Care Act, it basically says if your health insurance is going to pay for medical treatment, your health insurance also needs to pay for psychiatric treatment. And mental health parity is a great idea. And that Mental Health Parity Act did make a difference for some patients. However, we still have a long ways to go. Okay, we're going to skip through these ones. Social cultural issues. So culture is the learned pattern of behavior that shapes our thinking. It serves as a basis for social, religious, and family structure. It's a shared system of values that provides a framework for who we are. Race is that biological term. Culture, right, includes biology. And it describes a group of people who share distinct physical characteristics, skin color, facial features, hair texture. Ethnicity is the social term associated with customs, cultural habits, socialization patterns of a particular ethnic group. It plays an important role in preserving cultures, right? The different traditions that we have. Spirituality refers to a belief in a power greater than any human. And religion is that defined, organized, practiced system of worship. So what do we see in culture? Cultural values strongly influence thinking actions. A culture's belief systems developed over generations. It's formed by feelings and convictions that are believed to be true. And beliefs about mental health have a strong impact on the outcome of treatment. Values and beliefs help to define norms, which are culture's behavioral standards. Norms are the established rules of conduct that define which behaviors are encouraged, accepted, tolerated, and forbidden within a culture. While the role is the expected pattern of behaviors associated with a certain position, status, or gender. So the easiest when we look at roles are gender roles, right? Girls will wear dresses, they're the moms, they stay at home, they wear pink. Dads, they have jobs, they fix the car and do the outside chores, moms sweep and mop. Stereotype is that oversimplified mental picture of a cultural group, and they could be negative, positive, or traditional. Prejudice is that extreme negative stereotyping, and as healthcare providers, we need to know and understand stereotypes and our own stereotypes because we should not be stereotyping. And culture is learned through life experiences and passed from generation to generation, right? Culture, it's shared. It reflects its members, dynamic, changing, adaptive. But we also need to remember that an individual's behavior may or may not represent the culture that they're from. So we need to be aware to make changes. So influences of culture. Illness behavior, right? That disease, the physical dysfunction. When that happens, culture on its own has no impact on what disease you get. But illness and its behaviors are strongly influenced by culture. So what that means is anyone, regardless of your culture, can get cancer. However, what you're going to do about it could be strongly influenced by your culture. Mental illness, clients and care providers have different beliefs about mental health disorders. And Different cultures are going to define what is normal and abnormal based on their culture. We might look at something and be like, this is a mental illness, right? This person is talking about people being possessed. It is a mental illness. They have schizophrenia. They're delusional. However, in their culture, possession could be a normal conversation. So we need to know where our patients are coming from. Stress and coping. Adolescence is a stressful time. Women sometimes are in stressful roles, and how we cope in stress is going to be different depending on our culture. So when we do a cultural assessment, right, as healthcare providers, we all have to practice cultural competence. We have to look at our tendency to transfer our expectations onto a client. Just because I believe something doesn't mean my client should also. And we can't make those generalizations. We have to ask because every client is going to be different. These are different parts that we're going to see right in that assessment: communication, space, culturally, who is that culturally unique individual? What are the biological variations? The environment. What are the cultural health practices where they're from? The time. Do spaces, right? We talked in class about intimate distance, right? That's that within 18 inches. And social distance when we're a little bit farther away. Social orientation, that culture, that race, that ethnicity, what do they like to do for fun or leisure? It's going to be different in each society. So culture and mental health care. One thing we need to keep in mind if we're looking with culture for mental health care is refugees. Refugees are individuals who are fleeing from their home and looking to live elsewhere due to war or prosecution. We tend to see greater anxiety and stress-related problems in these individuals. So we have to get a thorough history. And we have to look at maybe who or what was lost. Did they lose loved ones? Did they leave all their belongings behind? We have to be sensitive to spiritual circumstances, religion, and all the different special circumstances among it. Haitian Americans, for example, may feel that an improvement in health was a result not of good care, but of mystical hearing power of leaves kept close to the body. That is not something we would believe in America necessarily. However, if we do have someone from Haiti and they have leaves, we might want to let them keep the leaves on them, right? I once let a patient pour salt around the building to keep evil spirits out. It's not going to hurt anyone. Let him do it. And that honestly, the not where it's not going to hurt anyone, let them do it, where this comes in from when we're looking at this question. If the family's bringing in natural and herbal medicines, if they're bringing in food, we just need to know what's in it so we can make sure that there's no interactions, right? If grandma's chicken soup is going to cure someone and is going to make them feel all better, then we let them eat grandma's chicken noodle soup. We just need to know what is inside them. We need to make sure we have an open conversation. Get the dietitian involved, get the pharmacist involved. But don't be closed-minded about it. Okay, theories and therapies. We got a lot of them. So, Freud, he, right, grandfather of all of this like stuff, that unconscious, right? He has that id, ego, superego, that iceberg where there's only a little bit that we can see and most of it's deep down inside. And those unconscious, those thoughts that we don't know about because they're so deep inside of us, they're what's having an effect in our behavior. So he pioneered this thing called psychoanalysis, and it's a way to explore the unconscious. And when we think psychoanalysis, we have to think that old school picture of the person laying down on a chair, right? That little reclining chair, talking to the psychiatrist who's like, tell me more about that. And that's where all of his stuff came from, right? He came up with that defense mechanisms. Defense mechanisms, we will go into more detail on test 2. So do not worry about the defense mechanisms too much right now. But for the basis, they are psychological strategies that we use unintentionally, right? We're using them unconsciously to avoid unpleasant feelings. And the whole focus of therapy when we look at Freud is that the causes of behavior or motion are things the client's not aware of. So we want the client to become aware of them so we can help the client process through it. We talk a lot more about these common defense mechanisms later, so do not stress about them right now. I know there are a lot of them. Denial is honestly one of the bases, right? Refusal to acknowledge conflict and thus escapes reality of a situation, right? When you look at your kid and they're like covered in chocolate and you're like, did you eat the cookies? Nope, I did not eat the cookies. They are denying it. So psychoanalytic therapies are based on Freud, right? Dream analysis. The id is seen more our unconscious in dreams. Free association, just having the patient kind of connect words together. And this was the main form of therapy that was done years and years and years ago. Analytical psychotherapy is also under Carl Jung. He's kind of founded this separate branch of psychotherapy. And basically, he believed that the energy that Freud labeled as sexually based was actually more general life energy, and that personality could change during adulthood and is actually influenced by future plans, goals, and dreams. So he had 3 different levels of the mind, similar to Freud. And he believed the primary effort in life was to gain more awareness. Developmental theories, Piaget looks at intellectual development. Personality is a result of interrelated cognitive and emotional functioning. Erickson is psychosocial. We see a lot of Erickson in nursing. He has 8 life cycles of the human stage, and each is marked by a developmental or core task. This crisis, right? This versus this. The uniting of the personality occurs as each developmental psychosocial task is mastered. So your personality is growing as you master each task. So this is Piaget, right? Sensory motor, right? Object permanence. Object permanence is that if I put a stuffed animal and I put a blanket over it, a child might cry because they think that the stuffed animal has disappeared. They don't realize that when the stuffed animal is under the blanket, that it is still there. Erickson, there's a whole lot. Remember, in this table, what we're going to focus on is that age and that associated quality, right? Being able to remember this versus that core task, that developmental stage. So birth to 1 year, that trust versus mistrust. If a child is left, an infant is left to cry all day long, no one feeds it, routinely, they're left in a dirty diaper, then that child learns mistrust and that becomes part of their personality. However, if a child is loved and trusted and they learn to trust their parents, if I cry, someone's going to pick me up, I'm going to get food. Oh my gosh, if I poop, someone changes my diaper. We learn trust, right? Autonomy versus shame and doubt, self-control, that self-confidence those 2-3-year-olds that they're kind of learning. 3 to 6, initiative versus guilt. Fantasy, right? They're imitating adults. 6 to 12, industry versus inferiority, right? They're starting to walk to school on their own. They're going to higher order tasks, right? They're learning. They're understanding rules. They're getting confidence. 12 to 18, identity versus diffusion. What am I going to be when I grow up, right? Peer groups are coming into it. 18 to 25, intimacy versus isolation. Am I right? I always talk about this quarter life crisis is the way I remember intimacy versus isolation at 18 to 25. Because 25 in my head is that quarter life, right? Am I going to be alone all my life or am I going to find a romantic partner? 25 to 65, generativity versus stagnation. We're looking at all of the other stages, right? Do we have kids? Are we moving with our lives? Are we growing in our career? Are we still teaching? Where are we going? Or are we just stagnant? Am I at 55 the same person I was at 25? And 65 to death is integrity versus despair. If we look back at our life, do we find meaning? Or do we look at that what might have been? The behavioral theory focuses on what the patient does, right? So if someone has a maladaptive, a bad behavior, and we want to change it into an adaptive, a good behavior, we focus on changing the behavior. Behavioral theories don't look at the why. They just look at the behavior. So Pavlov is probably one of the most well-known behavioral theorists, and he had the dogs. He would ring the bell and give the food to dogs, and he'd ring the bell and give the food, and ring the bell and give the food. And eventually the dogs learned every time I hear a bell, I'm going to get food. So the bell would ring and the dogs would start drooling, even if there was no food present, because they knew the food was coming. That is a behavioral theory. Humanistic looks at the whole person, right? Self-actualization. Our number one go-to for this is Maslow, right? His hierarchy of needs. We have, right? We're always, I would recommend double checking and looking at his chart and being familiar with all the different levels. But when we look at Maslow, we remember we're going to prioritize our nursing interventions, our nursing care plans, our nursing diagnoses. Which patient am I going to be most concerned about? A lot of those come from Maslow's because we need to look at what is the most important, and he helps guide that. So when we're looking at Maslow's, the bottom right, it's those eating, sleeping, drinking, sex, right? Eating disorders. If I have a patient with an eating disorder, do I care about why they're not eating? No, I care about the fact that they're starving. If we have a patient who just left their abusive husband, are we going to jump them straight into therapy? No, they might not have anywhere to live. I'm going to be concerned about getting them somewhere to live. And all the way at the top of the pyramid is that self-actualization, right? That be all you can be. Are you going to be the best person, the best patient a nurse that you can be? Not everyone will get to that self-actualization, but Maslow says we're continuously moving towards it. Systems theory, it looks at humans functioning within a set of related units. Kurt Lewin is kind of the one I've seen the most. He says that behavior must be considered within a total situation. He kind of rejected notions of past, future, cause and effect, and only focused on the immediate situation. So cognitive theories. Well, behavioral theory looked at what the patient was doing, those behaviors, right? I'm going to change the negative behavior into a positive. Cognitive theory looks at the brain. We want to look at the dysfunctional belief, and we want to correct that distorted thinking. And we want the patient to be able to identify and realize that their belief is dysfunctional. So cognitive restructuring is one of my favorites. I use this honestly with my kids all the time. And it's basically right treatment based on irrational beliefs and unrealistic expectations people hold for themselves. So for this, I think the example we talked about in class when I was teaching my kid to rollerblade, he was like, I'm never going to learn it. I'm horrible. I'm the worst rollerblader ever. And we're like, well, it's your second day learning to rollerblade. You're only 7. You've never done this before. Is that a fair statement to say? No. And we changed that thought. I'm not good at rollerblading right now, but with practice, I will get better. And we're able to see that one saying, I just learned to rollerblade, right? I honestly haven't rollerbladed since I was probably a teenager, so I might not be good at it. So saying the first time you do something you're going to be good at it is unrealistic. So now every time we try something new with my kid and he gets self-defeating, I'm like, hey, remember rollerblading. With practice, I will be better. Cognitive restructuring. Coping skills. What do we like to do to make us feel better? Individuals have adaptive and maladaptive coping skills. Where cognitive theory and cognitive therapy comes in is a lot of times when you have maladaptive coping skills. So drinking, alcohol. If you have a bad day and you go home and you have a glass of wine or a beer, right? That could be an adaptive coping skill. However, if you have someone who comes home every day and they have 3 bottles of wine or a 12-pack of beer, that's now a maladaptive coping skill. So we have to get the patient to realize that it's maladaptive, and then we teach them positive coping skills. And that's kind of where those problem-solving skills come in. When you're in a hard situation, how can you use new and different coping skills? How can you use that cognitive restructuring to change everything together? So again, behavioral theories, we're focusing on just the behavior, not the why. Cognitive theories, we're looking a lot about the why. We're looking at those distorted thinking, the dysfunctional beliefs, and we're trying to change those. Biobehavioral theories, homeostasis, an emotion is a reaction that causes the body to use its resources. The body wants to have that steady internal state. Stress adaptation theory, we get into this more when we talk about anxiety too. We have general adaptation syndrome, and in there's 3 stages. Alarm, oh my gosh, something's happening, right? Our body, right? You're driving down the road, and all of a sudden you see a cop car behind you. Even if the lights aren't on, your body goes into the alarm stage. Your heart beats faster. You start getting nervous. You get your hands at 10 and 2. That's that alarm stage. Now, if we're in the alarm stage for a while, our body starts getting tired, and that's where we get into resistance. We're working and we're working and we're working. Now, if we keep in that resistance stage and we keep trying to fight through this higher level of alertness, we can get to exhaustion, right? You're just feeling kind of sick from stress and anxiety. See increased rates of hypertension, arthritis, coronary artery disease. We'll talk about the effect of stress on the body later. However, right, we see more levels of illness and death in that exhaustion stage in patients. We can only stay alert for so long. We delve a lot into psychobiology next week, but it looks at how chemistry, how all the different parts of our body, right, our neurotransmitters, viruses, how that affects our mental health. And this is a much newer field. A lot of this stuff is still coming into play, but genetics plays a part. Right? Fetal development, viruses, that's schizophrenia. If the mother has influenza during the 2nd trimester, during fetal development, you have a higher rate of schizophrenia. Neurotransmitters is the basis for a lot of mental illness. Depression is low neurotransmitters. Mania is a lot of serotonin, right? Serotonin is designed in your gut. So maybe if you have an upset stomach, that can affect your serotonin too. So we'll dive a lot into that next week. I wish we really went into more of these versus just a huge slide. Florence Nightingale, right? She's that go-to. She started nursing really as nursing. She looked at, illness as the body's attempt to repair itself. Today's nursing theories, this is just a few. This was a whole master's level class that I took, and it was one of my favorites. We're looking at humans as a biopsychosocial being, right? We respond to stress in a unique way. Hildegard Peplau, she is my favorite nurse. She is to psych nursing what Hildegard Peplau is to psych nursing, what Florence Nightingale was to nursing. She is that first psych nurse, and she really looked at those interpersonal relations between client and the nurse. She looked a lot at what nurses can do with the patient and not to the patient. How can we come together in relationship with the team? Virginia Henderson, her 14 basic needs, that's how he really came up with nursing diagnoses. Gene Watson, right at the bottom, 1979, says nurses are a caring profession. Dorothea Orm, self-care deficit. We have to focus on where the self-care deficit is with our patients. So we have different levels of psychotherapy, right? Psychoanalysis, clients are looking at the meaning behind certain things, trying to cope. Client-centered, everyone has the ability within themselves to change. Cognitive therapy, right, is based on cognitive theory. So cognitive therapy is what helps the client identify and correct those distorted thinking, those dysfunctional beliefs. So in cognitive therapy, the client's role is focused on helping the client solve the problem. Behavioral therapy, again, is focused on just changing the behavior. Group therapies are absolutely amazing. We saw group therapy really developed after World War I and World War II. Soldiers, and I always say soldiers, Marines, sailors, they would be on boats, and it would take them a long time to get home from the Pacific, and they were together with people who had shared problems, and they could talk about it. And then when they came home, we had the advent of the VFWs, right? And all the veterans would go and sit in one area and talk about what happened together. That was really the first self-help groups. We tend to think about them just as like Alcoholics Anonymous, AA, or NA, Narcotics Anonymous. However, right, you can have it for anything. I once in nursing school, we talked about, I went to a brain tumor support group. It was an amazing group to go to. And to go to the brain tumor support group, we called and they let us come because we were nursing students, but everyone there had a brain tumor, right? So when we talk about self-help groups, everyone has the same problem. They can be formal or informal, but everyone shares the same problem, and they're not really run by healthcare providers. They're run by individuals. Online therapy, that's becoming much bigger. Teletherapy, telehealth is growing up, video counseling. We're looking at crisis therapy where you can even chat, send a text message. Somatic therapy looks at kind of like your body. Where is it? Biofeedback at the bottom, right? Biofeedback and phototherapy. Biofeedback, if you have your little Fitbit, you turn on your Fitbit and your Fitbit's looking at your heart rate and it's like, well, my heart rate's really high. Let me do some deep breathing to control my heart rate, right? So you take some deep breaths, you work on some relaxation, and you can see your heart rate going lower. You could do that with the Fitbit. That's the basis of biofeedback. Extreme biofeedback, we're going to hook you up to a lot more monitors. Phototherapy, we use with something called seasonal affective disorder. People tend to get sad in the winter, lack of sunlight. So for phototherapy, we sit them in front of a big light. Electric shock therapy, ECT, right? Old school, one flew over the cuckoo nest, I'm going to shock you. Transcranial magnetic stimulation, or that RTMS, we use a magnet to start stimulating the brain. So we have a bunch of different things that we can do. We ended with these last two questions. I'm going to skip through them. Y'all can read them. I try to keep these as short as possible, and I know this was a long lecture, so we're hitting an hour. If y'all have questions, if there's anything you didn't like how I explained it, reach out. I've already had someone start sending me messages with questions. I love those questions. Let me know what I can do to help you. Otherwise, I will see y'all on Monday.